want to do that, that will cut through a lot of the red tape. And so going forward, Matt will be the person you'll hear from most related to these meetings and whatnot, but again, team sport here. I'm gonna have Secretary Howard reiterate what your role is. We're calling the CREA. So Kansas Rural Health Innovation Alliance. So she'll go over that component as well.
And you of course know the role you played, earlier in this process before, the grant was actually submitted, but, we really see you playing an ongoing role, as the state advisory board, as we move into the implementation phase. And just as an aside, I mean, I think also having you all part of this is also an important part of sustainability, because as Secretary Sanders said, she'll be going down the road here and here, I will too. And so I think having you all around this table is also really important. We continue to see you, as we did during the development phase, as that specific primary vehicle for stakeholder engagement. You all have so many folks in your networks and so many stakeholders, so we'll use you as really that tool for stakeholder engagement. We think about collaboration, and if there's any maybe need sometimes to intervene with particular stakeholders, and facilitation with stakeholders as necessary. We also think we see a real role for you in promoting opportunities to constituents and facilitating participation of the right people around the table, particularly as we get into some of the planning around the specific projects. And then again, just committing to participating in quarterly meetings like this. We think they'll be more frequent during the initial implementation, and get a good sense today of how we're wanting to use you, because we're going to be taking some feedback from you about some to be going out and just getting some initial input and feedback from you. So again, know that we will leverage your expertise and your connections, and we really value you as part of the team to make this successful. And this back to Janet.
Okay. So one more thing, the eligibility, funding eligibility has come up, and in some code or also what's rural, right? So I would reiterate that we've had many discussions about this and many discussions with CMS about this, including yesterday. And what we need to remember, what you all can help us with, is carrying the message. This is not about one organization. It is about transformation and innovation of healthcare delivery, the system. That's why it's multifaceted. There's not all hospitals here. There's not all long-term care. It is about healthcare delivery. So it's forcing that innovation about how we play off each other to have a better solid system. So there are restrictions on use of funds, and some of them are no-brainers. We know what maybe a rural hospital sitting out in Western Kansas is. Obviously that's rural, but what does it mean? So to utilize the Federal Office of Rural Health Policies, define rural areas as where we're directing people. And there is a link there, and that is the best thing we can do right now. Now, I would say, just to clarify, should a non-rural organization have a project that they either want to submit or tack onto or whatever, that they would leave, but it would have to meet criteria. That criteria, and I'll quote CMS yesterday, it cannot benefit that non-rural organization. It has to benefit the rural healthcare delivery system. So it doesn't mean I'm going to do this with my bottom line increases. I'm going to do it because I'm going to provide care delivery in rural areas. They couldn't have been more clear on that. Should we have a project that is presented or discussion on something that might come up down the road, because year one's pretty baked, and Jody's going to talk about the timeline here in a minute. We would have to negotiate that type of initiative with CMS directly to make really clear and to see if they qualify. That is the best answer I can give you today, and I just wanted to make sure you all understood that. So in saying that, I'm going to turn it over to Jody, and she's going to go over the reporting requirements. And again, I appreciate everybody being here today. Thanks.
Appreciate the opportunity to talk about the timeline. I will say I'm recovering from this. We're no longer contagious, and I heard about that.
We tested her.
So we did receive our notice of award on December 29th, 2 days earlier than the congressional mandated deadline. Which meant that New Year's was not a lot of fun for all of us. We celebrated for 2 seconds and then said, now the real work begins. We have a revised budget due to CMS January 30th, and the Secretary Stanek noted, we did receive an additional $21.89 million, which will now be identifying those projects where we may have had to trim the original budget in order to meet the 200 million and from the additional training, certification, those sorts of expenditures that may have been missed in the original budget, and identifying those processes and getting that in. The interesting thing about the revised budget we learned yesterday in the meeting with CMS is they want an incredibly deep level of detail. Much deeper than I thought. Lane had put office supplies in the administrative budget that we originally submitted. Now they want to know exactly what office supplies and paper, et cetera. A level of detail that, quite frankly, I was surprised at yesterday's meeting. So we will be spending some significant time and reaching out to a number of you, seeking a deeper level of detail in order to meet those requirements, particularly for year one. And then we'll, in the narrative, explain how that can extend into future years. But this revised budget will be a deeper level. And there's no 20-page limit on this budget narrative. They want all the information to provide because, as noted, although nothing was disallowed, we now have to get approval for programs and projects for the funds to be released. And so that is really where this new budget comes into play. We are hoping that funds will be available for authorized expenditures in Q1, hopefully March 1st. July 1st, which will be here before we know it, is the end of the first reporting period because we have to submit our report on August 30th for our year one milestones and successes. That then will be reviewed through the month of September, and the actual official first budget period ends October 30th. But how much we receive for year two will depend on what we are able to report in that August 30th deadline. And so it is a very short timeline here in year one. Their goal is to then move toward consistency with the federal fiscal year. So we do have until September 30th of 2027 to expend the year one funds, but we have to be able to demonstrate movement in order to earn the maximum amount in year two and subsequent years. This is a cooperative agreement as opposed to a grant. Will give us flexibility, but also means we have to clearly demonstrate effectiveness. And then you can see here the second budget period is now October 31st. And then those funds extended by September 30th. And for every subsequent year, the funds have to be expended by the following federal fiscal year. All tied to satisfactory progress. So when we call and seem pushy, that's why we're being pushy. I just want to be really upfront about that, right? Next slide. So in terms of that expanded budget narrative, we're, as I said, addressing the 21.8 million. Very excited that globally the 5 initiatives have nothing was disallowed, but still means that we've got to work on those released funds. Potential areas for the expanded budget. As I noted, we had some areas where budget caps got in the way of being able to do, for example, like PACE renovation project. We only had up to a cap for those dollars. When the total goes up by an additional 21.89 million, the cap goes up, which is going to give us some flexibility to be able to allow funding for some of those projects that we're bumping up against the cap. And so that will be a first piece of that. Opportunities to also, as I noted, I identify where as the budget moved forward and we went, each program grew, what was available in year one or year two may not have fit under the 200 million in years 3 and 4 and 5. Now let's have more room in those subsequent years. So it's going to allow us to extend some dollars where it was a meaningful project that we included in the early years, but we were having to restrict funding in the out years in order to stay with the 200 million cap. So that is another area where we are going back to the original budgets and identifying where those gaps are. We're going to start with those things that we deem important enough to include in the application, and where do we have to restrict some funds. And then also wanting to identify any additional expenses as we are talking with groups around implementation, particularly on the priority projects we'll talk about in a moment. We have identified some things like additional funds for training, et cetera, that were not included in the original proposals that partnering organizations submitted, but we've identified, so we're looking to shore those things up with those dollars as well. And then lastly, increasing the amount of the regional partnerships and the emerging technology funding pools. Those are the areas where we're getting the most questions, where there seems to be the most interest in terms of submissions. Marty will be talking a little while about criteria for the regional partnership funding pool. And that any remaining dollars that are available to us, it would make sense for us to be able to put into those pools, so given the level of interest. Next slide, please. And so priority programs, we really talked a lot about how we get some milestones accomplished between now and July 30th in order to meet that goal of an August 30th, July 31st for an August 30th report. And so we tried to identify those where we believe there was, importance in getting dollars out into the rural communities as quickly as possible, where there is opportunity because there's great work going on, as Secretary Stanek mentioned, and now we can build on it to help us move more quickly, where there is good priority and focus that we can move things forward again to show as much progress as possible for that first report. The first is the value-based payment incentive program. You may remember this from our last meeting. It's really designed to help rural FQHCs, rural CCBHCs, rural health clinics, rural hospitals demonstrate evidence-based practice and quality as a foundation for other types of opportunities, clinically integrated networks, ACE participation, value contracting with commercial payers, direct to employer. At the end of the day, it all centers on how do you prove that you're providing high quality care. And so this is a quarterly reporting process whereby there are some significant dollars available to rural facilities for engaging in the initial quarter of reporting, how they're performing on quality, and then in subsequent quarters, how they are performing against national benchmarks. And so that is a program that we want to stand up as quickly as possible. There is already a reporting platform here in Kansas through the Hospital Association through HI. It's been in place roughly 25 years. It's been used very heavily by rural hospitals in Kansas. Other states like Colorado have used it for all their rural health clinics. So we know it's very shovel ready, if you will, from that perspective. And so our goal would be, Dr. Mercer will be sharing with you some recommended quality methods for your input. We're hoping to get CMS approval on those. And as early as April, be able to reach out to facilities and say, take a look at your first calendar quarter, January, February, March, and be able to report, to be able to launch that incentive program, all depending upon CMS approval, of course. The regional partnerships and the RAH conversion and transformation capital investment programs. Again, great deal of interest in the regional partnerships, whether that is a hub and 12 spokes, or it's 3 rural communities all wanting to come together and recruit a radiologist, or any number of types of programs. In the application, we sought to aggregate those programs that had statewide impact. But then we have a host of programs that were much more regional in nature. This would be a way to get funds out into those regional opportunities. Also, given the federal desire to see more rural emergency hospitals and other types of transformative work, the capital program is important to be able to move those federal priorities forward. So we're proposing those to be included in this priority. Accountable food is medicine. We believe that if you look at the applications from other states, we may have one of the most comprehensive food as medicine programs that is submitted in the country. It does seem to be a high priority of this administration, so we believe it is one where there will be a lot of eyes on our performance around accountable food as medicine. So important to our communities, but also important in terms of demonstrating our ability to move forward. It includes a heavy community health worker deployment in year one, 40 community health workers, 20 in primary care practices, and 20 in research and extension offices. That doesn't happen overnight. So that work group actually started meeting before we awarded. And Marty is driving the process to create a subset of work groups within the Accountable Food as Medicine Community Health Worker program, really taking advantage of the experience that KDHE has had in community health workers, that Sunflower has had in terms of food as medicine, that K-State has had in terms of some community health workers in research and extension offices, and really pulling all that together into a comprehensive program. Workforce. Yeah,
Sorry, can I just ask? I missed the meeting before the application was final. What's the difference between accountable food as medicine and food as medicine?
the difference is accountable food as medicine is also demonstrating the impact on total cost of care and measurable quality. One of the challenges in getting federal reimbursement or any level of reimbursement for food as medicine is being able to prove that there's return on the investment. And so the definition of some national organizations that are forming, et cetera, and there is some discussion in Congress, a couple of bills being introduced, a Center for Medicare and Medicaid Innovation potential award to be announced. All of those are focusing on what they call accountable food as medicine, because we really have to prove that it's an investment in healthcare. And that's why we're using that terminology. Unfortunately, food was not included as an allowable expense. And so while we can connect patients to the existing resources, to the farmers market vouchers that KDHE has offered, to the food banks, to the various charitable organizations that are there, that our initial work will have to be in connecting patients to those existing resources while we seek to continue to grow those resources through other sorts of partnerships and opportunity. But we were not able to include food as a possible map effort, unfortunately. And we'll continue to look for other funding opportunities as those are introduced, as CMMI awards are launched, et cetera, to try and find a way to pay for the food. Workforce education and training, you will not be surprised that I believe is the number one issue that was submitted through the request for applications. Workforce in the rural communities is a clear need and effort. And HealthWorks under the Hospital Association has agreed to support a number of those workforce initiatives. And then we have scholarship programs as well for through Board of Regents, Campus Bridging Program, Dental Association, et cetera. So there'll be a number of different scholarship programs. We'll look to see how far we can get in structuring those programs and either launched or prepared to launch in this first year. Interfacility transports has come up in many of the rural communities as being a gap. Their local EMS teams are stretched, and yet they need to get patients to another level of care or back home again, and there are not the resources to be able to do that. So it is a priority to get at least a couple of those regional interfacility transports up and running. And then the Anchor Hospital Advancement Program. It's become clear that rural facilities are depending more and more on their regional hubs, but the regional hubs themselves are struggling. So this is really how can we provide support to the regional hubs so that they in turn can support the rural clinics and rural hospitals that rely on them. And so at this point, I'm going to turn it over to Dr. Mosier to talk about the details of quality reporting under the value program.
Thank you, Carrie. So one of our goals, particularly one of the goals that Governor Kelly spoke about early on when we first began having conversations about helping with the rural health transformation program, was what can we do to quickly get dollars back out into the rural healthcare system, rural providers. And so one of those was our value-based incentive program, which is basically developing a quality improvement program for clinics and for critical access hospitals. The clinics include our CCBHCs. And so if you step back and you think about, well, what are quality measures that are currently being reported? Because if you're already being paid for an activity or reimbursed for a particular activity, then it doesn't qualify in the Rural Health Transformation Program. So come up with 5 quality improvement measures for clinics and 5 for hospitals and CCBHCs that don't already get reimbursement. Yeah, that was the task. So what you see here on the next slide is what we've basically come up with. So for hospitals, now some of these you may go, well, wait a minute, sepsis has been something that CMS has been collecting quality measures and payment for since 2015, 14. And that's true. But what we're doing is we're taking a few things and we're basically changing it around. And what can we do to improve on what we've seen from the work we've been doing for the last 11 years that impacts patient care, but it's something that they can easily report and qualify for reimbursement. So we'll cover some of these. So STEMI is another one, but there's a lot of effort around, whether practices want to become certified by giving guidelines through the AHA program. And what we found is when we first started our project, it's Care Collaborative around STEMI, stroke, and sepsis, was that hospitals that were giving lytic, breaking open, busting the clot with medications because they were more than an hour away from a cath lab, they were averaging about 74 minutes, with the goal being 30. And so by developing evidence-based protocols and developing their order sets and educating around what were the evidence-based guidelines, all of our sites rapidly within the first quarter moved from an average of 74 minutes down to about 50 and have since averaged around 35. They haven't quite gotten to the 30, but they've improved. So what we want to do is continue to push and drive to get to the national benchmark of 30 minutes for the lytic hospitals. Now, for hospitals are within an hour's drive of a cath lab, the goal is basically get the patient in and out the door 30 minutes. And that's very challenging. When we began, the average was 140 minutes. It's gotten down to as low as 45 in some cases, but average is pretty close to 50 minutes. So what we're looking at is pushing that down to get it to 45 minutes. And part of the reason for the delay is what Jody talked about with the challenges that our regional hospitals or receiving hospitals is through COVID with the decrease in staffing and whatnot, they've created a lot of barriers that I don't think they naturally recognize impacts the quality of care that we can provide in their settings. So for example, as a provider, give an example, let's say Edwards County. I have a heart attack patient. I'm further than an hour away from the cath lab. So I know I need to send this patient. So I call my nearest cath lab, which means I'm not talking to the cath lab. I'm not talking to the cardiologist directly. Oftentimes I have to talk to the emergency room provider, give them the patient history. And then they may say, yes, we'll take the patient. Or in some cases, they'll say, no, now I got to call the cardiologist on call and you get to present this all again. So they build in these delays that they don't stop and think about. It makes it very challenging for our rural hospitals to get that patient out the door in the national benchmark timeline. So we're going to continue to push on that and hopefully working through some of these other programs with our regional partners to recognize how they impact the quality of care at the rural hospital level. So you see the timelines there. Door to lytic, hospitals were doing really pretty good. Actually, when we began, the average time to get the lytic on board was about 72 minutes. And that's dropped to just a little over 60 minutes. So they were doing great before, but unfortunately, only 3% of patients eligible for the clot busting drug were getting it before we began our work. And now we've gotten that up to the national benchmark of around 20%. So that means 17% of the patients that presented with a stroke who weren't getting the appropriate therapy are now getting that. So we're seeing much better outcomes, which reduces that total cost of care, because in the past, they probably would have come back into the community with a neurologic disability and been admitted for long care. So we're still going to be pushing on that. And if they present outside of the 4.5 hour window, the opportunity that we give the clot busting drug at the rural hospital, We still want to move them on, right? Because since 2019, now the evidence-based guidelines say if they have a large vessel occlusion, and we get them onto a comprehensive stroke center where they can go in and do either arterial clot busting, medication delivery, and thrombectomy, take the clot actually out of that vessel, the outcomes are so much better. So that's why we continue to push to either get the lytic on board at 60 or get the patient consult and get them ready to move on to that comprehensive center by 60 minutes. So continue to drive the improvement. Now, sepsis, as I was speaking about earlier, they have a 3-hour bundle. And we know with sepsis, it is a time critical diagnosis. So once it's identified and believed due to a bacterium, getting the antibiotic on board in the first hour truly has a time impact on the outcome. But CMS used a 3-hour bundle. That's because large medical centers didn't want the 1 hour because it's just more challenging for them. So the 3 hours been what's been proposed, but there are a number of elements within that bundle that have to be met to qualify. One of those requirements is to start on 30 cc's per kilogram of body weight of IV fluid resuscitation. And we often find a lot of sites fail on that for a variety of reasons. One is you're in a rural setting and you've got a sick patient, oftentimes they're elderly, oftentimes they already have underlying heart failure. If we're giving a lot of fluids quickly, we're going to put them in for florid heart failure. So their fluid lungs can fill up with fluids and whatnot. So they are very tentative about giving that amount of fluid. But what they fail to recognize is that sepsis with shock, with decreased blood pressure, is what we call the distributed shock. And so to determine if you're able to resuscitate, you've got to give fluid quick enough to find out if they respond to that. And if they don't, and they're still hypotensive, it's very important to get the blood pressure raising medication of vasopressor on board. So they kind of came out and reiterated these as the national guidelines in 2021, which we've been educating on, but we still see some reluctance. And mostly it's due to, I can tell you, when I was both in pharmacy school and as a resident, we were always trained, we didn't give a vasopressor until you loaded up the pipes with fluid. And so they've been reluctant to start the vasopressors, and it's kind of, medication they don't use every day. And so there's a lot of worry and reluctance. But I think as we continue to train and push on using this as a quality measure, that, hey, if you've got somebody that you've identified with sepsis, they're hypotensive, their blood pressure is less than 90 systolic, you start them on your 1 hour bundle, all those activities that you have to meet, labs, cultures, IV, get the antibiotic going. But your goal is to get started on the 30 cc's per kilo IV fluid resuscitation. So that means in the first hour, you should get at least 600 to 700 cc's on board. And if their blood pressure is not coming up, then by the end of 2 hours, you should have a vasopressor on board. So that meets the national guidelines, national benchmarks, and we'll hope will continue to drive the improvement that we've already seen around sepsis management, which again means better outcome, earlier recognition that this patient needs to move on to a higher level of care, which comes back to all of our transportation and partnerships with the region. Now, diabetes and heart failure are two common conditions, chronic conditions in Kansas that also we find lots of readmissions for a number of reasons. A lot of it has to do with integration of care, care coordination. And so we're developing a checklist, a discharge checklist. There are certain elements in there that should be met in order to qualify. And so this one will be kind of an attestation that completed all of those elements for both heart failure and diabetes. Any questions on the hospital ones?
So Dr. Bob, when we're looking at these, are these going to be credited to the hospital just for reporting, or do they have to meet certain criteria or in order to be able to access the dollars?
Yeah, as soon as we kind of get a general consensus that these are okay measures to look at and use in the quality improvement initiative on this project, then what we'll do is we'll sit down with QHI to look at, how can we make this as simple as possible? Because I hear plenty about the challenges of reporting data. And so what can we do to make it possible? And we know that the first quarter, if not the first half of the year, it's going to be paid for reporting because we have to develop what's the current benchmark? How well are we doing across these rural hospitals? And then from that benchmark, we'll decide, what should be the expectation. And then future payments will be based on meeting that. And that will hopefully will have to be increased each year because of the success that we'll be seeing. So mostly just, yeah, take a look and we'll provide more detail as we get the approval for these particular measures. So in other words, just like we tell our rural hospitals we work with, we develop the protocols, we develop the checklist. But hey, this is just guidance. It's based off the evidence-based guidelines. You don't have to use the auditor.
Excuse me.
The main thing you have to do is report the particular elements that we think impacts readmission rates and patient outcomes. And so the checklist, I think, will be one of those. If you develop your own, it's on the record. It's what you use when you discharge the patient home. You've got a paper copy of that. Report that. Yes, we may have to audit, to make sure everybody's on board and above board and whatnot, but that's as simple as we can make it. It would be the ultimate goal. And yet drive the outcomes we're after. Now, the next slide is a little bit more challenging because, as I said, CCBHCs all have a number of quality measures they have to report just to maintain their certification. We have a number of clinics and hospitals that are members of accountable care organizations, which have quality measures that as they report and perform at a certain level, it increases their likelihood of getting shared savings. So to me, that means those measures are reimbursable, so we can't use them. We may have to get some clarification from CMS, but that's how that I've heard and from some FAQs interpreted why we're looking at some of these. So again, some of these that we've chosen have been removed either by NCQA or MIPS or CMS, whatever organization requiring the reporting. But we think there's still a value that we're bringing them back. So I'll cover that. So one of them is really, I think, feeds into our food is medicine. But if we're going to capture a BMI and expanding this quality measure from either, for the CCBHCs, it focuses on children and adolescents. And in some of the MIPS reporting and ACO stuff, it has focused on adults 17 and over. We're combining those to children through adults. And we're looking at a couple of other measures that really identify patients at risk of metabolic syndrome and other conditions. And get into a little bit more of that with one of the other measures. So we're looking at a BMI and a waist circumference for adults. We're looking at a waist circumference and height ratio for children because there's enough evidence to show that there are certain levels where they fall above or below their increased risk of poor health and bad outcomes. And then adding to that, actually a tie-in to a community service organization or one of the projects and programs that will be going on as we roll out this activity. So, for example, the virtual diabetes prevention program referral, and that there's going to be an asynchronous diabetes prevention type program, patient-facing technology where New Health, I think, is one of the technologies where you can basically log on and it'll do patient education around nutrition, weight loss, physical activity, et cetera. So it's documenting that follow-up has not only just been put in the plan, but it's actually happened. Yeah, and that one's the most complicated as far as tracking and documenting. Lung cancer screening, we've had efforts around the state on this. And so one of the biggest challenges once you identify an abnormal finding on CT is getting them in for consult. And then it's also recommended that this be done yearly for patients at risk. And so we just find a lot of challenges about what happens with the follow-up. So we're working out a few details on how can we improve on this to really meet what the national benchmarks would be. Postnatal depression screening. So this could occur at any setting that you see a patient, right? So this could be a CCBHC, this could be a rural health clinic, you name it. So this would be making sure that they've been screened. And if this is a patient, let's say that they're seen at a CCBHC, but they're also seen at a rural health clinic, could both sites report on that patient? Yes. They'd rather we do that than miss a patient that somebody assumes somebody else has already done the work, right? Prenatal care, again, this could also be clinics that do not do prenatal care normally or do obstetrical services. But if someone comes in, because they've missed a cycle and they want to know if they're pregnant, you get the pregnancy test back positive, you could go ahead and have lab draw your prenatal lab, do the initial intake, right? And then refer on for obstetrical care. So our goal is, and this is something KDH&E, their Graham measures, they look at, the percent of patients who get their care started in the first trimester, because we know that has an impact on outcome. And so our goal is to push for that. Cardiovascular kidney metabolic syndrome. This is something that not a lot of folks know, but there have been some measures around kidney health. It's basically those who are directed at trying to identify chronic kidney disease in an earlier stage. This takes that and says, there are a lot of things that put you at risk of developing kidney disease. And those are some of the same things that increase risk for cardiovascular morbidity and mortality, which is one of our biggest drivers in mortality in Canada. So there are a number of measures on that, but it's basically, again, kind of falls back to looking at the BMI, the waist circumference, and then doing a kidney health screening, which is basically looking at calculating their estimated glomerular filtration rate, which can be done on a simple app. The other is the drawing lab to look at their urine albumin level, urine albumin creatinine ratio, because as more albumin shows up, the more likely there's kidney damage. And then also screening for all those other drivers, diabetes, hypertension, cardiovascular disease, and pre-diabetes that leads to the development of chronic kidney disease. But having positive cardiovascular kidney metabolic syndrome findings overall increases the morbidity, mortality, and offers us an opportunity to identify patients who need more intensive intervention. All right, so public health, behavioral health integration. This really came up a lot in a lot of our conversations. Was just that when patients referred, whether it's a specialist or CCBHCs, that they kind of get lost. We don't know, why this medicine was changed and why they're on medicines. And so it's more the forced collaboration, particularly around medication reconciliation between primary care and behavioral health. And then the other is basically for any time a patient is discharged. So if they're in inpatient psych, let's say, and they're discharged CCBHC, make sure there's a med reconciliation. Then the second part of that is make sure that med reconciliation communication occurs with their identified primary care provider, whether that's within your clinic or in your community. All right, so those are the clinic. Complicated, I know, but we think we can identify ways to make those as simple as possible.
Dementia screening from us.
Oh, I missed that. That's partly because I probably should have a screen. Yeah. So one of the other projects currently is that, in the past, identifying patients with early cognitive impairment is a little bit of a challenge. Sometimes they don't come in to be evaluated until the problems are advanced enough, the family recognizes it. And so what we're looking at is improving the screening for early dementia and Alzheimer's. And there are now new biomarkers, blood tests can be done for patients that have certain risk factors for Alzheimer's that you can draw. And if identified as positive, then you know that these patients need to have higher levels of care where there are now more advanced therapies available. Therapies that we probably aren't going to be administering in our rural hospitals and whatnot, but more at the regional sites down the road. So it's kind of taking something I think eventually will become a new quality measure that will, one of the third-party payers like CMS will be promoting. Kansas is just going to be way ahead of is what our proposal is. So what I'd like is, think about these, and if it's, an absolute no-go on any of these measures, and this is impossible, we can't do it, let us know. But meanwhile, what we'll do is we'll start putting in how the information will be collected, how much of it is administrative, how much of it is pulling data out of the EMR, which we know how easy that can be. And so, again, I want to find a way to make it as simple as possible, but yet accurate enough that we can track, because these will be some of the outcomes that we'll have to be reporting. Number of sites participating, number of sites, meeting, the benchmarks, et cetera, whatnot. That will demonstrate, that we're implementing according to what our guideline plan, timeline was for the rural transformation program. So hopefully we'll have, more funding available in years to, 3 to 5. All right. Appreciate it. I'll turn it over to Marty.
Stop funding pools, which was, I think, a unique aspect of Kansas application. In part, as part of the solicitation proposals, there are a number of organizations that suggested initiatives that we could go to 4 or 5 hospitals, or be an urban hospital, non-rural hospitals, supporting multiple regional hospitals. Similar types of arrangements that for an application that was targeted on statewide initiative. And was not really the point where you could select winners and losers as to who would be funded for those types of initiatives. So for that reason, Kansas included in its application this regional partnership grant program, or by now, want to call everything by an acronym, the RBG. This is a program we want to launch as soon as possible. The funding currently in the budget for this program in year 1 is $38 million. That likely will be increased as part of the 21.89 additional million. Never call it 21 million. Don't do that to me. It's 21.89 additional $1 million. The eligibility for this program begins the issue of who is rural, as we've discussed previously. This is intended to target rural providers broadly defined as hospitals, CCBHCs, rural health clinics, private physician practices, long-term care facilities, licensed substance use disorder organizations. So that is the target, is to build partnerships among those providers, either by type or across types of providers. But appreciating that it is often beneficial to have a non-rural facility as part of those partnerships. Those organizations could be applicants. They could be part of a partnership that is for which an application is submitted. The test will be whether the benefit of the partnership endures to the rural community, as opposed to, as Secretary Stanek said, benefiting the bottom line of the non-rural facility. So again, the intention is to be very broad and in the availability of these partnership agreements. We don't define partnership. We leave that to the applicant to define what that partnership would look like, what the rules of the road will be for that partnership, what the implementation plan will be for that. Nor do we tell them how much money they can apply for. What we do say is, or at least, and all of this is proposed. If I said everything is written in pencil at this point, I should have said that. But what is proposed is there's $38 million available in year 1. We're not obligated to spend all of that $38 million in year 1. We may push some of those dollars to year 2 if we don't get the level of applications we hope for. But appreciate that our goal with this program is to have a broad statewide impact. And so if you are one region that's requesting $100 million, or even out of the 38 million, you're requesting 30 million, appreciate that the interest of the state would be to expand the reach of that $38 million. We also are concerned we don't want to duplicate other programs that are already part of the state's RHTP plan. So be sensitive to that as well as you apply for these funds. You have in the packet that was distributed what is the current working version of the request for applications for the rural, the regional partnership program. Again, it may look like it's printed in ink. It is written in pencil. All of that is subject to change. And your input was critical, because we certainly want to approach, potential applicants, and indicate this was criteria that was vetted by a number of organizations, and identified as appropriate. The request for applications, we intend to release as soon as possible. This whole CMS allowable versus authorized issue is causing us a little bit of heartache. The direction received is that yes, the state can commit dollars, but if you're not eventually authorized to spend those dollars, it's going to be on the state side. So we can certainly release the RFA, a target date of February 1, but making it very clear as we release the RFA, if the program is not authorized by CMS, the dollars would not be available. If we release the RFA by February 1, goal would be to have applications back to us by March 13. Afford the state 6 to 8 weeks to review those applications and make funding announcements by mid-March, with the initial performance period beginning on June 1. This is one of those programs we look at, say, need a milestone for year 1 to report by the end of August. We have these dollars in the field as soon as possible. These awards would be for 2 performance periods. Obviously, in year 1, it's a shortened performance period 1, and then a full year performance period 2. So you would propose a budget that covers 2 performance periods. You would receive funding for performance year period 1. Obviously, funding for performance year 2 is going to be dependent on level of achievement on your implementation. For the purposes of application, an applicant would be required to submit written commitment by at least one other eligible provider to participate in the relationship. So if I'm hospital A and I'm proposing a relationship with hospital B and C, I have to have a written commitment from at least hospital B or C to move forward with the application. If I'm non-rural facility, I would need to have at least one eligible provider providing written commitment. Obviously, the greater the written commitment that's submitted with the application, the stronger that application would be. We've required a detailed budget across the typical SF424 budget categories, and a detailed implementation plan so that we can gauge the success of the organization moving forward with its plan. The criteria to evaluate these applications, as I said previously, statewide impact, non-duplication of other programs. But then if it's good enough for CMS, it's good enough for us. We'll use the criteria that was detailed with the notice of funding opportunity by which state applications were evaluated for purposes of awards under the Rural Health Transformation. And we referenced in the RFA the specific provisions in the NOFO to which folks can evaluate. They are not exactly what you expect them to be, sort of. Is it a sustainable project? What's the impact in terms of the community that's targeted, and similar types of considerations? And there's a scoring matrix that's included in the application. So it's a big utilize that purposes of evaluation. Any questions? I'm sure you have many.
I'm curious, in your conversations with CMS, it sounds like a lot of these different components and the smaller parts of them still have to be run back by CMS. Did they give you any indication? Do you have to turn all of those things in as a block and they review them? Or are they going to kind of do one-offs as something gets off the ground more quickly? Did they give you any indication?
Well, okay, so this is the fingers crossed version, because the original budget narrative was 20 pages. And I mean, we used every last inch of that to describe the initiatives, the programs, the projects, and it covered all 5 years. Our understanding now is, this is a working theory, is what they're expecting is a more detailed budget analysis for year 1.
And so do each block within that and
Right.
maybe allude to some of these things.
Exactly. All of it goes in January 30. My impression, and again, team, if you agree or disagree, was that CMS may approve it in bits and pieces. They may say, okay, projects 1, 5, and 7 are authorized and we'll release the funds as requested for that, but we need more detail on 2. I don't know what numbers I just used, But we need more detail on these programs. So that's our hope. And certainly that's CMS's drive because they're just as interested in getting results out of this as soon as possible as all the states.
Yeah, I would add, they are still hiring. They need to hire like 10 more people. They have some interim roles and lead people, for example, like if it was me, I'd be doing somebody's work that might be able to hire and backfill with. So I think that is a good and a bad problem, really, because it's a first. So to me, we can help drive it and mold it. Like, let's fill their head with ideas and tell them what we think they should do. They seem very amenable to being flexible. They also gave us some inroads on, hey, if you have a vendor and you want to get us that piece ahead so we can get that approved for you, let's do that. And I mean, I think it's ours to lose, right? I think we just need to keep that communication very frequent and ongoing. And so they don't have, like, to your point of blocks. It's like, let's go. If we have something, let's go. And that's what we're going to do. So very open. Oh, she was the head of it.
She was, I think we were introduced, I think, one of the first states that had those meetings, but they were, for example, if any of you were following this last fall around the guidance that was available out of CMS, most of that, and they did 2 webinars, but the majority of like the detailed level guidance was coming out in frequently asked questions. And some of the responses to those frequently asked questions were just annoying as all get out. Because they were great ideas that basically been cut off at the knees by these FAQs. The project officer told us yesterday that the FAQs, as we say, are written in pencil. And that if you can make a case why you should spend money in a certain manner, we're willing to listen to that. Because the FAQs are not binding. The only binding guidance at this point is the elements that are in the NOFO and the provisions of the statute that created the term. And of course, the notice of award, which just simply mirrors the NOFO. So that's sort of like, ooh, we've got some freedom here to explore what these are.
I think because they're looking for, sometimes I don't like the term innovation because we think we're innovative, but they're looking for innovation. And so I think they want the states to provide that for them. And I think that we have a good idea and they say, we'll change. Absolutely. I think the FAQ shouldn't be discounted. A lot in there probably is binding because it's no-brainer stuff. There's a lot that's questionable as far as what the word binding means too. But I felt really good about, for what it's worth, the office we're dealing with out of CMS is a distinct office, newly created. So it's theirs to build and we can help them build it. So we should be optimistic.
Yeah, wrong. Yeah.
Yeah, just a couple quick clarification items. I know we're kind of still putting this together. So has there been much thought about putting a maximum amount that a entity or a partnership can request, or is it just hope? And then secondly, is there any expectation that there's going to be local investments, that there's matching, that people can bring dollars or commitments to the proposal funds?
You're gonna hate me so for this. What do you guys think? That's what you're here for. Our theory was no cap because the idea is appreciate it needs to be a statewide impact, so don't ask for too much. If you ask for half the pool, most likely that's gonna be a knock on your application. And the local investment, I think, just proves sustainability. You can say, hey, we're gonna put up this much, then that would be something that demonstrates to the review committee that there's a strong sustainability for this project. But feedback from you all. What are your thoughts?
Another question, will you work with them if they come in as half of it, if you really like it, and there's that back and forth, is that? We'll try, okay.
These guys know what they're doing when it comes to bringing out
I
stuff.
just-
Absolutely.
Your timeline's so fast, I just.
It is so fast.
Just
We don't want
them
to.
up.
Yeah, I think just I'll just say this from the governor's perspective. She is very focused on this impacting really rural areas and those areas where we can demonstrate transformative change. I think just that alone is going to be like our first thing. How does this transform the existing delivery system? And that's going to either enhance or knock a lot of people out if they don't have a strong argument. So good point. I think we'll know it when we see it. We have not, it gets to the point, we have not discussed that related to, not in any great detail, because we didn't know what the budget meeting was going to consist of with CMS yesterday. pleasantly surprised again that they approved things, but now we know, and honestly, they were a lot focused on the paper pencils and travel. They really were. It was kind of amazing. So Elon's gotten to them or something, but, it was interesting. So they're not even scratching the surface on the actual projects. I am confident, though, once we do detail that it's Reading versus Blue or whatever we're gonna put in the line item, we're gonna make the case strong that they won't question it. I'm confident about that because we had a strong application to begin with. So, back to the caps and things, I think we're gonna know it when we see it and we're gonna have to discuss it, right?
Could a non-provider entity apply on behalf of like a consortium of providers or like city government or total government or
So long as that element, that critical element. is-
benefits the rural
But
community?
that's the fiscal community. We don't really care who the applicant is. I mean, maybe be transparent, you know, if you've gone. We'll know it when we see it. I
Yeah.
hate to say it, but yeah, I think if it was a city government, sure, I think that'd be appropriate.
What if you have like a PPS hospital that's not in a non-rural area, but has rural health clinics that are in rural counties?
You betcha.
But that benefits the bottom line of the whole organization, but benefits the rural community. How does that? Do you know what you see it?
Make the case of why this benefits, I mean, don't make the case of how it benefits you as a non-rural
Right.
facility, make the case of how it's benefiting and transforming, that's that word, transforming, rural communities. Dr. Moon?
Yeah, just to that point, go back and look, excuse me, at the NOFO, there were some examples of a variety of projects and in a couple of places, they said, yeah, has to demonstrate that this is not a top-down type project. That this is really, because that would show that you really are just dragging the rural partners along. They're not actually part of the planning and development process. So the fact they mentioned that in a couple of locations of examples in the NOFO, I think that's something that they might look at in review of how we're implementing some of these funding tools.
Now I'm gonna ask you to do the impossible. Oh, sorry, Kira.
I have just a quick follow-up question to I think Brenda's question, which is, so they'll approve this idea of the rural health, the rural partnership grant program and the funds that are available. To what extent will individual awards need approval? I mean, to your point, yeah. So will there then be a second round of approval after they're awarded, or that's not how it's proposed?
That is not what we're proposing. They may come back and say that, well, really? But yeah, hopefully not.
We did, is this the subrecipient thing? Is this a discussion on the subrecipient or? Because they didn't act like they needed to know
No, I
that.
don't think so.
Mm-mm.
They did.
We asked that yesterday. We asked that yesterday.
They were like, yeah, if you got subrecipients, we have your throat to choke, so we don't care.
Yeah, and that was the message I heard on that call yesterday.
I'm just translating for people. What they really meant to say.
They will no doubt know what prerequisites and all of the restrictions and everything they have in the notice of funding, but that's reflected in our application process. And then I think once they're comfortable with that and they know that we're looking at it, it's just passing on through another section. So who has to meet all those same requirements now?
And so we have a lot of hospitals in our state that are rural that are managed by hospital systems that are out of state. Who apply, so let's say Garden City Hospitals managed by a system out of Colorado Springs. Can they apply?
Oh, no.
Okay,
It has to
out-
be Kansas entity. Has to be Kansas entity.
It does have to be a Kansas.
We did. At least that's what we said. That's again, at least as it stands now, that may be a great
Yeah,
example.
well, I think around our borders, there's a whole lot of
Right.
hospitals that are actually owned by and operated by out of state.
We want the the reason, the logic behind having a Kansas organization apply is we want the money managed in Kansas. Right, but again, if you think that's a bad idea, feedback. Okay, so this is, I said, I'm gonna ask you to do the impossible thing. It's a really multi-part impossible thing to do. So you signed up for this, right? Well, no, you were told you were on this, trip. Sorry. You were voluntold. The goal is, well, that's not a goal. Our deadline for submitting the revised budget narrative is January 30th. We want to front load as much detail as we can regarding at least the priority projects into this budget narrative. Again, The reason those were identified as priority projects is broad statewide impact, higher likelihood of success of quick implementation. That means we would intend to include with that budget narrative, the RFA, the application, in a more finalized form. Again, what you have now is in pencil. And as you noted at the bottom, it says, do not distribute. Because we don't want to create an expectation among providers at this point in time that this is what's going to happen. That is always problematic when you said submit something. Yeah.
So that raises the question of, like, you want us to begin building supporting this to be very good. So what are the methodologies for how do we get the feedback and evidence?
Right. That, as I said, the impossible task we're asking you to do is, can you share these concepts? Again, as you share these concepts with them, you may take portions of the document and say, but continually communicate, this is not the final version. We're looking for feedback. You can't, don't expect that this is what the final document is going to look like. Don't create an expectation. So that's the impossible task we ask you to do. You hit the nail on the head, is engage with your constituencies, provide feedback. If you need the Word version of these documents to provide edits, we can do that, right, Matt? Okay, Matt says we can do that. I always have to ask him before I make promises. But that's what we really need to do. So yes, feedback, so we can really know that this is a program that works. And then the second half of that is, please promote this program to your members. Please, please, please. I mean, in a perfect world, we'd be receiving applications from several different constituencies. I mean, I love hospitals, but I don't want to award 30 hospitals, right? Sorry, Sharon. I want to see clinics involved in this. I want to see the cities being engaged with their providers in this. So it is a true experiment. It's $38 million. How creative can you be? How can you transform healthcare throughout the state of Kansas? You'll see that there are subsequent fundings years. So this program will continue. The fact you get money in year one would not be a guarantee of getting money in subsequent years. The amounts do go down because our intention, again, is to have maximum impact early in the process. And hopefully, again, those numbers will grow as Jody finds more dollars. Questions?
So this isn't related necessarily to the grant program, but you had made a statement about priority projects. You're going to want more information, and it's good to give you that information in advance. How do you know that one of your projects that you recommended is a priority?
Matt, can you go back to priority projects? This should look familiar. These are what we identified. Remember, we did a webinar in December when we completed the application. These were mentioned then. These are priority only in the sense of this team, right? It's sort of like where we think we can make statewide impact, and we have the greatest chance of success with these programs. So
if we were a part of one of these, we would want as much information from us now.
Exactly.
The more detail that they talked about, for example, if this is a partner organization that has done some of this work before the pilot, or who has successfully partnered with KDHE or KDAD or another agency, we want to really be able to document all of that historic success, prove the reason we chose this partner to include in the application, with the goal of them that it was pretty clear. You can make that case outside how far. If not, then we're gonna have to go back and we'll have to go through the whole process.
That's the RPGP. And again, I don't want to, yes, we want your feedback on the criteria. Absolutely. That is invaluable. But please start the conversations with your constituencies that this money is going to be available, that they should anticipate seeing an RFA, hopefully by February 1. And that again, we want those dollars out the door in June, if at all possible. So it is an immediate opportunity. It obviously is going to involve some planning by folks. To your point, Maria, if it's kind of half-baked, I think we do go back in and say, can we help you develop this idea? If any of you want to serve as mentors for applicants, especially those of you that are in this business of awarding things, Brandon, as I look at you, let us know, because we would love to share with folks, hey, if you're working on an application, and you need some assistance, digging through the budget, we can send you to folks that aren't part of the team that will necessarily be evaluating the applications, but have experience in this area. So if you are willing to do that. Yes, thank you.
I'm big on timelines, so I know you're throwing out, March 1st and February and whatever, but how shall we direct people here today to give us the red line version input, and or what's your timeline on wanting that back? What would be the optimum? So we don't, everybody knows they have a homework assignment going out of here, I guess, a little bit.
Well, January 30 is when we turn into pumpkins and submit the new revised budget. Obviously, we want to discuss it around the executive team, so back that up a few days. So I think
Today's the 13th.
today's the 13th, 10 days, the 23rd. Is that reasonable? And I'm not gonna, you can turn in your homework late, just appreciate that it may not receive the same very in-depth consideration. Just to help us do our job optimally, we need that back from you from January 23rd. Please, if you're working on it, you've got a feedback team and you're not going to meet that 23rd deadline, just let us know. And because we want, we want the brilliance that's going to come from the community mental health centers, right? So
where should that go back to Matt? Okay,
Matt.
so
Okay, Matt?
if Matt distributes the Word version, not to be widely distributed, for you to redline, he could be the conduit to get it back. And you're welcome to contact the peer collaborative as well, but as far as the formal for tracking, we do have executive committee meeting. That's this group here today from the state and care collaborative. We meet as needed, but every week for sure. So thank you.
The process was in the February 1-ish is when the documents available and proof of apply. There be like a webinar or a debate conference or something, they come and listen to someone and get their questions answered and understand what they need to do.
It's a darn good idea. I guess we should do that.
Yeah, I like that
I
idea.
like that a lot.
Okay.
It's gotta help. We'll do a webinar anytime. No, I hope you kind of appreciate that with this group. They're insanely flexible, so we want to do whatever we can. I've never heard Jody actually utter the word no. I'm waiting for the day she says no. Okay, cool. Anything else? And Dr. Manager, I'm just gonna go back to what you said, talking about the value-based incentive program. See, that is just, he doesn't, he's like all about the clinical and he doesn't mention the money, so I'm gonna mention the money, okay? For a hospital, each quarter, it's $50,000. So it's a potential $200,000 a year. For each clinic, and again, remember that includes RHCs, private physician practice, CCDHCs, FQHCs, anyone that's got an address in a rural area, remember? That's $25,000. So yeah, you depend, and I think, did we decide by TIN is how we were gonna do that?
I don't know.
We haven't yet. It's not TIN,
Individual and but
by TIN.
so it depends on your organization, if you're an FQHC versus RFC, et cetera. How you are designated as the organization.
Can you say those amounts one more time?
50 for hospitals, 25 for clinics. And again, the cycle would be basically you do a quarter, right? You have 2 months to do your reporting, your QHI. So my first quarter ends March 31, and we're talking Q1, because we're talking paper reporting. But March 31, so you'd report by May 30, and you'd have a check hopefully by June 3rd. So we're trying to get this, again, money out as soon and as quickly as possible. I'm going to float an idea with these guys that for the first quarter, it may just be you sign a letter of commitment to participate in the program and get your money. And we're kind of pushing that. We'll talk about that. That's just an idea. Okay. Ruby, let's talk. Are we PH conversion transformative capital investment grant program? Yeah, that's a mouthful. I was like typing along going, that is ridiculous. So I have created an acronym called RECAP. So REH is those hospitals that are transitioning from either critical access or PPS hospital to rural emergency hospital. What's been identified as an obstacle to that conversion, one of many, but one significant obstacle is the need to really transform your physical plant to become more outpatient focused. That may be transitioning inpatient rooms to outpatient capabilities. It may be taking beds and turning them into a Jerry psych unit, but whatever that may be, having dollars available to these organizations to support that type of capital improvement. Alternatively, there are a number of stories, again, we heard through the proposal phase of hospitals saying, if we could just get the funds to help us buy an MRI, we know there's a demand in our local community to increase that service availability. People are having to drive 30 minutes, an hour to have that testing done. So that would be an example of transformative capital. It isn't that I need a new growth. Unless you can make a case that growths are transformative, and maybe in some instances they are. But we're not talking about just maintaining current physical plant. It's really expanding the capacity in the community to deliver the service. And so making the case as part of your application of why this is transformative to this region. Again, expectation here is that this is individual applicants. This is not a partnership type of program, but you can cross programs if it's appropriate, right? So I may have a regional partnership application over here that has a supportive element over in the transformative capital. We wouldn't rule that out. We just don't want 6 things in one application, right? So we're going to encourage folks that for each partnership, submit one application. For each type of transformative capital, submit one application. This would be limited to folks with a rural address. So again, maybe the applicant would be some other entity, but the capital has to go to someone with a rural address. Yeah.
So I just want to clarify, we're going from non-metropolitan areas to MIO, right? So you're going to have potential parts accounts and other components that are now eligible.
Yes.
Okay,
Census
just
tract.
that.
Yes.
So if it's a consensus track, the physical plant which you apply for has to exist.
Has to fit. It's like doing the work grant, right? Overall policy, am I going to
Yeah.
qualify in other areas, Marshall County, that whole census tract?
Correct.
Okay, thank you.
Enter the address. Corp says you are or are not rural. You know,
That makes
MSA definition and a grant CMS used. Like, I think I followed this argument she was giving on shit because we asked, you know, what's rural? And the project officer said we were using really expansive definitions of rural because we knew all states had to participate for the legislation, right? And when you get to New Jersey, the lowest funded state, run into issues because there's not a lot designated for this rural. And so they were using very expansive definitions. And they said, you know, effectively use the definition that works for your state is what it came down to. And because of the MSA, you know, Sumner County, perfect example, right? Part of an MSA, but there are census tracts designated as rural. And that's what we would use as the definition. Probably true.
Thank you so much.
I love black and white answers. Except that you remember that high school in Indiana that's split between the time zones down the middle. So I'm hoping we don't have any facilities like that. Otherwise, this tracks pretty closely the mechanics of the rural partnership program, regional partnership program, excuse me. The dollars are less, as you can see, 18 million in year 1 and 9 and 6 in year 3. It's only 3 years available on this program. Again, funding constraints. I think something else we learned yesterday from the project officer is there will be some ability based on experience year over year to adjust programs, which is we're not locked in specific lanes at this point based on the application that you can make the case to CMS of why you would expand, track, revise certain programs as part of the plan, which is I thought great news.
I want to clarify on this one, this would still mean you're getting ready, but then there's a whole branch under Ashley Goss's area of licensing where CMS. Now we're waiting for another part of CMS to approve all of your readiness, but this at least gets you closer to being able to be considered for the conversion. But does not mean this is a magic way to get there, right? And I don't mean you were implying that, but it could be misleading to people like the legislature that this is what happens.
Do we have the initial this first budget application?
I don't think so.
You don't have to identify yourself.
Which ones?
This would be in first year.
No. No,
Y'all good? Oh, Judy.
Can you talk about the other funds? We want to make sure that we're not just, these are the first two we're proposing to launch in that initial period, but you want to talk about the other funds?
Absolutely, great idea. Three other funds. Part of the quiz here is, does Marty remember the application very well? There is one fund, which is part of the workforce programming, which will be dollars available to organizations to do targeted training. Again, this, when I say it's not a priority, it certainly is critically important, but it's not where we're starting. So we'll take lessons learned from the other grant programs to develop this. But this is, I want to start a new respiratory therapy program where Dr. Moser will be medical director. We were joking this morning that he's a medical director for an RT program. But I need funds to help start that up, or I need dollars to support accreditation. So that's what the purpose of that program will be. Again, hyper focused on individual facilities and their programming. The second is I know emerging technology. No, what's the other one?
Emerging technology.
What's the yeah, I'm gonna forget. There's a $2 million line item for the sovereign nations to work together, the 4 sovereign nations in Kansas, identify opportunities for improving their rural clinics. So we have those dollars available for them. And then emerging technologies is kind of a dual. It's the idea is with so much coming on the market. If any of you have been following the JP Morgan conference out in San Francisco, it's just completely overwhelming, the amount of technology coming out. And for any rural facility, even any non-rural facility, to keep track of that, to identify the appropriate product for certain use cases is really challenging. So part of this program is to convene a panel of experts to sort of provide a good housekeeping seal of approval for certain products. And then having funds available to providers to be able to apply and acquire those types of technologies going forward. So we've got some work to do in finding our panel of experts. We are certainly open to any suggestions for that group. We've had a couple of conversations already, but truly to sort of provide these rural providers with that level of support, that centralized sort of advisory role. Yep.
So the breadth of that can range from AI or analytics to potentially even EMRs for small rural centers.
Yeah, EHRs are kind of scary because there's like a pretty low cap in the application of how many replacement EHRs you can utilize. But it could be.
Even if that was potentially 3, I mean, that's still
Yeah.
something really small.
Right. True, yes. That fund's small right now. I think by the time we got to Initiative 5, we're running out of steam. No, I'm kidding. But that fund is one target area for increasing the amount using that 21.89 million. But yeah, it's, again, I think we're going to leave it to the experts, right? And say, really, where do you want to put the good housekeeping seal of approval? Where's the really beneficial program? What year will that be?
Is that in your one?
Oh, hopefully in year 1. Yeah, at least convene the panel. And again, if you all have suggestions on folks that would be interested or willing to serve on that, please let us know. Because we really do want to get folks, you just don't want to get the talking heads. You want the folks that understand rural. I mean, there's obviously some talent we can pull in the state on that particular issue. I've gone way over my time by like an hour and a half, right?
no, you're good.
Anything else? You know where we are. Eventually we respond to email. If we don't respond within a few hours, it's because there's a few hundred emails ahead of you on the list. No, I don't mean that. Thank you. Coming today and listening to this and all the work you're going to do with the assignments we just did.
Well, I know we're at time, but we want to leave any time or open it up for any questions or any additional discussion that you guys might have about any of the vast amount of information we shared with you guys today. Yes.
I understand the dog being and that being expression, no problem, but we have clinics, obviously, that covers. That are still right, say, is there any opportunity to this would be the first stage if we don't put on other needs?
Yeah, there's two things to think about in the plan. One is for sites that as we move more and more to the at-risk model for participating in ACO, which many of our rural sites that just showed you, the government doesn't understand rural health care, number one, but if they want to participate in that, then the reason they're not getting picked is they just haven't really demonstrated by claims data analyses and other things that we're ready to be a part of it. So we have an ACO readiness plan project to basically partner with a national ACO organization come in and will help with, kind of standing up a shadow ACO, a look-like.
Yeah.
To get the experience practices, the funding started, and then hopefully they're more attractive for the national organizations, larger ACO projects that are currently going on. There is a lot of quality improvement involved, as well as utilization, you name it, with the ACO model. And so the incentive-based quality improvement is kind of for those that are even at that level, haven't done a lot of that, other than what's required for MITs and things like that, is moving that forward, but doing it in a way that actually can impact patient outcomes, total cost of care. So, so if they are participating in ACO, our hope was to identify 5 measures that they could report on that was not being already reported as an ACO member. Or Blue Cross Blue Shield quality improvement, any current reimbursed for quality improvement. That's why it took a little inventiveness to come up with 5, but in 5 that have an impact.
Well, that's great.
Yes. What's it? Yeah, I want feedback on this. You have till tomorrow. No, really, the goal is we want to get this moving so that we can, and as Mark said, you can look at the time frame and go, wow, end of April, we've got a report by, end of May in order to show that you're reporting and get paid for reporting, right? Well, that's going to be pretty tough to learn 5 new quality measures, which I can tell you right now, providers are going to go, you just keep adding more. You just keep putting more. And I appreciate that, but this is one that you can see reimbursement, the impact of your efforts more quickly. It feeds into a number of other rural health transformation program projects. And we will try to make it as simple as possible. So the first quarter, if not the first year, half year, could just be standing up and saying, yes, we'll participate and we're going to attempt to start the reporting. We have to work with QHI to develop all of the, how's that platform take in this information and be able to demonstrate that, hey, so-and-so did connect, did report. And then boom, that report comes out, ADHD looks at it, they say, okay, this is clinic, this is check. So it could take 6 months to really start getting a flow of reporting coming on a regular basis from a number of clinics. Clinics may need some help with that. And, and that's part of some of the other, programs, projects that have some practice facilitation. And, I'm out and about across the state a lot. I'd be happy to stop in. Most of it's really getting very familiar with your EHR. And you create a register, what's required to pull any data for that register. And then that makes the tracking and historical, just into that one. And some of it is make it simple. The EHR we found, we started our chronic care management off of a spreadsheet. Because none of the EHRs had all the 5 domains, we had to make sure we're identified, reported, and analyzed, treated, and made in order to meet the compliance. And so In some cases, the best thing would be to do a paper trail that you identify that patient as each visit. As they come into the home, and you put out your checklist, what has to be done with each time and mark that off. At the end of the month, you assemble those. Somebody sits down and enters it in before you got. I mean, yes, is that a lot of work? And we don't have a lot of resources that for people who do that yet. But this, yeah, the long-term impact, the fact that you get paid at the end of the quarter for that effort, rather than waiting like ACO. You do all the work for a year, you wait another 9 months to buy that to get there and save.
Right. Okay,
So,
thank you, Scott.
well, and again, I think, appreciate, your inquiry and the answer, and there'll be more to come on all of that, but we, need to exit this room and we have an online meeting, obviously, so we'll discontinue at this point. You know where to reach me and anybody, on our executive committee that's here. And again, be positive and thanks for working with us as we build this, while that, airplane's flying, right? So.